Good morning to everybody, and I thank the organizers for inviting me to speak on this topic titled Rheumatic Heart Disease, Is It Still Relevant? As we know that rheumatic fever, rheumatic heart disease is a prevalent, yet it's a preventable cause, but yet it is a prevalent cause of NCD of infectious etiology. Rheumatic fever, rheumatic heart disease is a disease of poverty, overcrowding, poor living conditions, and lack of access to the healthcare services to identify high-risk children with sore throat and treat them to prevent the rheumatic fever. So with the result, the rheumatic fever, rheumatic heart disease is commonest cause of heart disease in the low and middle income countries. This shows the global distribution of rheumatic heart disease. And the blue dots of different sizes basically indicate the increasing prevalence of rheumatic heart disease. And you see it is the most prevalent in South Asia, South Africa, and Pacific countries. It is rare in the countries in the northern hemisphere of the globe. And these shades of different colors of the countries basically indicate the change in the age standardized prevalence of rheumatic heart disease from 1990 to 2013 as per the reports of Global Burden of Disease Study 2015. You find that countries in the southern hemisphere of the globe are the ones where the age-adjusted prevalence is increasing at variable rate, while from the countries in the developed countries, it is decreasing at a variable rate. So rheumatic heart disease still continues to be an important cause of morbidity and mortality in a developing country like ours. So if you talk about the globally, it is estimated in the Global Burden of Disease Study 2022 that globally around 46.3 million people are affected with rheumatic heart disease. And annual mortality every year about 0.38 million people die because of this disease. And if you see the change in the age-adjusted prevalence and incidence of rheumatic heart disease, it has increased by almost 14%. So this signifies the lack of effective primary healthcare services in the low-income countries to detect early and prevent the disease. And however, the morbidity, mortality because of rheumatic heart disease reflected by the death rate, age-adjusted death rates, as well as the age-adjusted DALYs have decreased by almost 53%. This indicates improvement in the management of patients with advanced rheumatic heart disease. However, we have to do lot more in the area of primary prevention. ICMR had, if you see in our country, in the context of our country, ICMR had done a population, the registry, the survey studies in the school children at different points of time. You find there's a steady decline in the prevalence of rheumatic heart disease amongst the school children. We have also done a two-point survey study amongst the school children in the Shimla city as well as the rural area of the adjoining Mashobra block. First in the 1992-93 and second in 2007-2008, where we screened almost 15,000 school children clinically and followed by the echocardiography in suspected cases. During this period of 15 years, there has been significant improvement in the indicator of socioeconomic indices. The per capita income has increased, and number of institutions providing healthcare services to the per lakh population has also increased. So with the result of this change in the social determinants, there has been significant decline in the prevalence of rheumatic heart disease among school children. We did not find a single child with rheumatic fever in the second survey study, while in the first we had 0.7 per 1,000 children having rheumatic fever. So to assess the impact of rheumatic heart disease and its outcomes, the Invictus registry, which is one of the largest registry where 13,696 people with rheumatic heart disease are enrolled from 138 sites from 24 low and middle income countries prospectively and followed them for over a period of 3.2 years. They found that rheumatic heart disease is basically a disease of young with mean age of 43.2, and substantial proportion of patients had advanced, moderate or severe valvular heart disease, and 72% patients were females, and large proportion of patients were complicated with the heart failure, atrial fibrillation, pulmonary hypertension, and with stroke and or systemic thromboembolism. And 13.6% of patients already had undergone valve replacement with surgery, and 8% patient had undergone balloon mitral valvoplasty. And overall, 41% patients were on secondary prophylaxis. So aim of this Invictus registry was to find out two incidence of the all-cause mortality. The secondary outcomes were the cause-specific mortality and was the hospitalization for heart failure, recurrent rheumatic fever, and infective endocarditis. This shows that overall, the mortality rate was 15%, and incidence of mortality was 4.7% patient years, and heart failure hospitalization was 2%, and incidence of the stroke was less than 1%. They also analyzed the data to identify the risk predictors of the adverse outcomes. They found that patients who had undergone valve surgery, valvoplasty, and secondary antibiotic prophylaxis, and patients from high-income countries were the important determinants of the low risk of mortality, which was statistically significant. However, increasing age, congestive heart failure, presence of pulmonary hypertension, atrial fibrillation, prior history of stroke, and systemic thromboembolism were associated with increased risk of mortality. We also reported long-term outcome in patients with rheumatic heart disease based on the HPRFRHC registry that we started in 2011. Until 2018, we had enrolled 328 patients of rheumatic heart disease prospectively. It was a single center IGMC Medical College. Unfortunately, 614 patients, which constituted about 26% of the study cohort, were lost to follow-up. We collected the baseline clinical data of the patients, and we followed them annually in person or through the telephonically to estimate the incidence, the outcomes which are predefined, like all-cause mortality, stroke or systemic thromboembolism, heart failure hospitalization, and we also analyzed the data to identify the risk predictors. In our study cohort, around 13.9% of patients had undergone balloon valvoplasty at registry, and about 10% patients had undergone valve replacement with surgery. And in this subgroup of patients less than 40 years, 92.2% patients were receiving the secondary prophylaxis. We found that the incidence of composite major adverse outcome, which was basically the combination of all-cause mortality, worsening heart failure, hospitalization, and systemic thromboembolism stroke, was 3.98%. And heart failure incidence of heart failure hospitalization was 1.92%, and all-cause mortality was 1.73% patient year, which was significantly lower than what was reported in the Invictus registry. Incidence of stroke was less than 1% in our registry also. We also analyzed our data to find out the predictors of risk of mortality. We found that increasing age, education below primary level, severe valvular heart disease, NYHA function class 3 and 4, presence of right heart failure and stroke were the major important risk determinants of the composite major adverse cardiovascular outcome. We also found that the patient who had undergone balloon mitral valvoplasty, the risk of composite major adverse outcome was significantly lower, which was 62% lower than people who did not undergo this procedure. So these data basically indicate that large proportion of patients, when they were seen first time in the tertiary care centers, already have severe valvular heart disease. Substantial proportion of patients are already complicated with the heart failure and other major complications. And therefore, it basically emphasizes that it's important to strengthen the primary healthcare services to identify these patients early so that they can be monitored, risk stratified, and high-risk patients are provided the tailored treatment timely. Rheumatic heart disease, since it's a disease of young population, it affects the woman during pregnancy. In order to assess the impact of rheumatic heart disease on pregnancy outcome, MPEC registry, which is the single center prospective registry, was reported from the Madras Medical College by Justin Paul et al., where 1,000 plus women with 129 pregnancies were enrolled. And rheumatic heart disease basically constituted 42% of the total study cohort. And 60% of the patients, the rheumatic heart disease was diagnosed first time during the pregnancy. They assessed the maternal outcome, which constituted maternal mortality, new or worsening heart failure, thromboembolism, and composite of these individual outcomes. The fetal outcomes were fetal loss, preterm birth, and small for gestation, and composite of these two outcomes. They found that overall the mortality was 1.5% and 15.2% has composite maternal adverse outcomes, which was primarily contributed by the heart failure. And 1/3 had adverse fetal outcome. So they found that the patients who had LV systolic dysfunction, patients who were having prosthetic heart valves, severe mitral stenosis, pulmonary hypertension, and heart disease diagnosed during pregnancy were the important predictors of the outcome, adverse outcomes. And they found that 8.6% of the women with prosthetic heart valves had the mortality. So rheumatic heart disease is an important cause of morbidity and mortality in pregnant women, particularly those who had prosthetic heart valves. So therefore, it basically, again, emphasizes the importance of early screening. Preferably before conception, they should be identified if they have rheumatic heart disease, and they need to be risk stratified, and multidisciplinary treatment. And treatment is required for high-risk patients during pregnancy, during labor, as well as the postpartum.